Tonight, we're very lucky. We have another great Missoula resource we're going to present here. Dr. Andy Puckett is a hand surgeon. He lives in Missoula. He went to Purdue as an undergraduate, then went to medical school at University of Iowa. Indiana, sorry. Did his orthopedic residency at Indiana University and went to studied at University of Utah for a hand fellowship. He's been in practice here for 20 years. I think you saw my hands at one point. He's gone to Honduras about 10 different times, working with a group here in Missoula called Missoula Medical Aid. And he's going to share some of his experience. So, great. Go ahead.
Well, thanks for having me, everybody. I gave this a lecture last year. I don't know that it's the same lecture, because I couldn't give the same lecture twice, even if the slides had words on them. But as Nancy said, I've been in practice here. I'm a hand surgeon at Missoula Bone and Joint, and I became involved with Missoula Medical Aid about 11 or 12 years ago, and have made 10 trips to Honduras. I'll kind of talk a little bit about Missoula Medical Aid and kind of the genesis of the organization, and then a bit more about my personal experiences with volunteer work, and specifically with this volunteer work, and kind of how I became involved and how I feel about volunteer work in the medical field. Anyway, Honduras is, some of you may or may not know, a very impoverished country in Central America that is a very beautiful place, very mountainous, not huge mountains. If any of you have been in the Smoky Mountains, it always kind of reminds me of the Smoky Mountains. It doesn't, in the lowlands it feels tropical, but once you get up in the mountains it's pretty temperate. A lot of it was all forested, but it's a lot of it's been a lot of the timber has been harvested to make room for agriculture, and most of the people are subsistence farmers, and they're dotted all over this landscape. And as you drive around, you think, oh, it's all just forest, but then you look and you see a little roof tucked in the woods, pretty much everywhere. In 1998, Hurricane Mitch, which was the worst hurricane of that season, developed as a Category 5 hurricane in the Gulf of Mexico. It was actually downgraded when it hit Honduras, but as you can see, this is the border of Honduras here, and this is the hurricane. I mean, that thing was giant. And it downgraded, but what it did was drop officially about 36 inches of water on Honduras, and some unofficial gauges said it was as high as 75 inches of water in places. Now I'm nervous. Bulger's going to correct me most of the time. Anyway, the population of Honduras at that time was about 7.5 million. About 1.5 million, that's 20% of the population, was left homeless. 11,000 people died. A group of Missoulians, as not only Missoulians will do, but as Missoulians will do, mobilized and created a group of several people that went to Honduras almost immediately. And their experience was, I think, humbling. I think they did a lot of hand-holding. I was not involved in that organization. They did a lot of cleanup, digging a hospital out of mud. There was mud everywhere. There were mudslides everywhere. They came back, and from that was born the Missoula Medical Aid. And It has been a ever-evolving organization since, this trip that I'm getting ready to go on in April will be the 50th trip for the organization. So from that trip, it's generated 3 to 4 trips a year since then. Medical, I'm going to put up a little flow diagram of what our organization does here in just a minute. But the medical end started as primarily primary care in small villages. And from that, a couple of subspecialties have started going. One is OBGYN routinely, and then orthopedics relatively routinely as well. Okay, told me to point at this. Honduras is, as I mentioned, Central America. It has both a Atlantic and Pacific coast. It's not a huge country, but does span the whole peninsula. We concentrate our efforts on 2 areas. The first area that where the group went was down in this area around San Lorenzo. There was a lot of mudslide issues in that area. Then we also, over time, have identified and go to this town, La Esperanza, which is up in the mountains. And that's where I always go in the development of this orthopedic wing of our organization has really had to be concentrated just because of our resources, both people and materials. We can keep things there. We've developed a relationship with the hospital and now have strong relationships and go back. I think we don't have enough resource to do that in multiple areas. So our mission, Missoula Medical Aid, is we work with rural and impoverished communities in Honduras as they seek to improve health and access to health care. And we do that through both the medical end of things, and we have partnered with a number of organizations that we've identified over the years. Save the Children has kind of taken us under their umbrella. They pick us up, they coordinate our travel, they coordinate the villages that we go to, they take us out there, and then we plug in the care. I will only superficially tell you about the primary care thing because I don't do that, but that's all out in the small villages. The orthopedic care is all provided at the hospital in this town that we go to, which is a town of about 20,000 people. But we've partnered over time. They're our primary partner, but we've also partnered with the Lions Club, and we've developed a couple of programs. We brought dentists down many times, but have identified a Honduran dentist that we can hire for about as many dollars as it costs us to send one dentist down there for 1 week who sees patients a half a day, 5 days a week down there. And these are all, they see all underprivileged people who can't otherwise get access to dental care. Likewise, through the Lions Club, we also have an eye clinic down there that's not manned that frequently, but also on multiple days weekly or multiple half days weekly. The other thing we've created, which has been a super interesting project, is these community medical boxes, which are small pharmacies that are in these little villages, so people can go get their routine meds. We kind of provide the seed money to generate that, and there's usually a health volunteer who's minimally trained, who mans that. It's locked. We first bought the meds. They sell the meds at a slight profit so that they can then re-up the medications, so these families can just go get their medications there rather than having to take a whole day to go into the main town, find a pharmacy, find a way to pay. Medical brigades, as I mentioned, we have the primary care brigades, we have some OBGYN brigades, and then orthopedic brigades as frequently as possible. The other limb of our organization has been through a number of development projects locally, agriculturally, and then one of our docs that goes down frequently said, why are we seeing these patients who are chronically have upper respiratory problems, and they all cook in their homes under an open fire, and we've generated a closed stove that cost, the original ones cost $15 a piece to build in these people's homes to create a chimney and vent the smoke out of these homes. If you look at the homes, you go in the homes, there's a little gap between the roof and the top of the walls, and that's how they let the smoke escape before, but it just all billowed in there and they lived in it. So we've tried to create better home environment. We've tried to create some early child nutrition and stimulation programs in the small communities. We generate funds to fund nursing scholarships for local kids to go to nursing school and come back to town and provide care in their own town. We have a large dental project which brings dental hygiene and toothbrushes and fluoride to about 2,500 kids. And then we've helped with some local agricultural development to create then these subsistence farmers group corn mills, some the local indigenous people are their tribal name was they were Lenkins. There's a farm to market type setup where people have we get them to grow help them to begin to grow certain vegetables like a butter lettuce, but they all have the same basket to bring it in. They have a cleansing facility and warehouse, and then transport, and we've identified a market for them so that they can sell this product, get a little bit of money, maybe be able to send their kids to school. So that's kind of a quick overview of our entire organization. Do you want to ask a question?
What's the national health care system like there?
Is there a national?
There is national health care. I think it's very difficult to compare it to what we have going on here. My take, and as we ask questions later, Dr. Bulger may be able to answer that question better than I can. I know, anybody can come to the hospital and get care, but they have to go purchase medications if they need if they have surgery, if they want any pain medication, they have to buy it, and so it's very limited. Yeah.
I was thinking about those medical boxes for things like tuberculosis. Does the National Health System provide medications for ongoing problems that they could use? You set up the system for them.
All these meds are purchased by people. I mean, the government's not paying for their meds. Yeah. So maybe I've killed this thing now. There we go. So Honduras, as I mentioned, is mountainous, a lot like the Smoky Mountains. The roads are windy. There's no federal interstate system. The thing I like about this picture is you see this road. It looks like about a 4-lane road of which there is absolutely no paint on it. And people drive essentially wherever they want. That bus is going about 4 miles an hour. That truck's going probably 25 miles an hour. People don't drive hellishly fast, but the roads are super windy. They have improved over the years since I started going, but it's too wide, and they'll be coming down too wide, and you're in fear for your life the whole time you're driving up. Honduras is the murder capital of the world. 90 murders per 100,000 people, double the second highest country in the world. The only time I'm really scared when I'm in Honduras is from the time the plane touches the ground until I get to La Esperanza. Actually, we turn off on the last road. I always feel much safer. I don't know if that's warranted, but Save the Children always gets us, always puts gets us in a number of vehicles, gets us up there. I do feel relatively safe. I mean, we're not all sequestered in a single bus or anything like that. This is the facility that we stay in La Esperanza. This is the Save the Children facility. There's educational rooms. It's kind of little school rooms almost, and then there are administrative offices and a little kitchen and things back in there. A couple of bathrooms. I should have taken a picture of the shower. It's not enjoyable, but it's doable. But a lot of us will stay just outside, and we all stay on cots, which we keep down there. Everybody goes out and does their thing, and then we all reconvene in the evening there and kind of get ready for the next day, get medications ready, etc. But that's where we work out of. Every place in Honduras is surrounded by pretty secure fencing. This gate's closed almost all the time except for during the day. And there's a guard at the facility that kind of comes and goes. It's not an armed guard, but it's a caretaker, and he locks and opens for us. Clean facility. This is a typical picture of town in La Esperanza. There's kind of ongoing markets. Most days, a couple of days, it's much bigger. Most of the streets have been dirt, but they're gradually being paved over the 10 years since I've been there. One thing that's changed dramatically in Honduras since I started going has been the cell phone. And I think that's probably going to change healthcare more in that country than anything. I used to say, is there any way we could get these patients back next year to reevaluate them when we come back? And it was essentially no. And now we get when we see the patients, first thing we do is get their cell phone numbers, and we can get some back. So we get a little bit of follow-up now. And I think that will, over time, be a real boon. Colorful, this is the hardware store. Just a kind of fun picture of it ain't Ace Hardware. Every house, it seems like, or at least one or two on every block, has these little stores they call pulperia. And this is the person's house, the pink house here. And they have this little bodega built on, and they sell Cokes and phone cards and a bunch of stuff that's bad for you, like chips and ice cream. This is a picture of one of the nicer farms on the way in. A lot of vegetables can be grown in that area because it's so temperate at 6,000 feet. I'll show a picture in a minute of a lot of diverse vegetables, but traditionally everybody grew beans and corn, and that's what they subsist on. And one of our attempts is to try to get the locals to grow different things. They can grow things year-round. Out comes one crop, in can go anew. This is in the marketplace downtown in La Esperanza, and everybody brings their own food, and they kind of do their market thing, and they cook their own food, and they buy a little bit of food. But that's kind of a very typical day in their market. Here, like I said, you can see the variety of fruits and vegetables, and they're just beautiful. A big pile of oranges. Not everything's quite as organized. The beans are a pretty awesome sight when you walk through the market. Maybe so, maybe not. Dried fish, just in case. I haven't had the guts to try the dried fish yet. So I'll talk a little bit about what I do there and the people, and they're just beautiful people. There are kids everywhere, and I see a lot of kids with congenital anomalies, and you'll see a lot of pictures. There are some trauma pictures in here because what I do, it doesn't faze me at all, and I apologize if you're squeamish at all. I'll try to warn you. I can't remember when they're coming up exactly. So if anybody, this is a mother and her son. This kid had an elbow fracture. One thing I see down there that I don't see here is injuries. They're kind of historic interest only in the United States. We treat them acutely. They don't get treatment there at all. They heal. A lot of them are untreatable, and certainly untreatable when you're only there for a week. But this little kiddo had a bad elbow fracture, and we did what's called an osteotomy, where we cut and realigned his bone, and his mother was very happy. And here you see this kid on post-op day 1. He looks pretty good. I think a kid here would probably still be screaming. They hardly say boo. Anybody want to guess how old that gal is? 22. She had a 3-month-old elbow dislocation we treated. Here, elbow dislocation, if it's 3 hours old, would be getting ancient. She'd been out for 3 months. We took her to the operating room and did what's called an open reduction. So we had to take everything, tease it apart, and got her back in. This is in the early years, so do I know how she did? Unfortunately, no. But I think I can almost for certain tell you that she did better than she would have without it. Just another family standing outside the hospital. This gal came every morning saying, "Are you going to take care of my daughter? Are you going to take care of my daughter? Are you going to take care of your daughter?" Which, of course, by the end of the week, we were able to. A woman just on the streets. One thing that she's carrying corn to make tortillas. You see people walking around with their cornmeal paste all on their heads in the mornings, carrying it around to make tortillas, take it to the oven. I think the battery's dying.
You probably just push the arrow.
That's probably true. So this is out at one of the primary care clinics. These are usually held at community buildings such as the school. And these are all the local people in their kind of traditional outfits waiting semi-patiently to be seen in the clinic. Some people in town are of good fortune and can go to school and have a uniform and make it to school. We see those kids every day where we stay. Other kids are barefoot and hiding behind a truck. Probably not nearly as fortunate. And you can see also this is a clean area in town. There is so much litter down there, it's unbelievable. If you can look beyond it, it's a beautiful place, but up close it kind of hurts. This is the hospital. This is where we do our clinic. I don't speak Spanish, so this fellow with me is my interpreter. I think I pressed him, speaking medical and getting him to, but Harris is his name. He used to live here in Missoula. He's an accountant for the Forest Service and had to move to Albuquerque. We miss him. I had a great trip with him. That's kind of the evaluation phase. And the way my week works down there is we usually get down there. They've made an announcement on the radio that there's going to be a specialist in town. And when it's me, a hand specialist is coming to town. And the people just arrive and they wait patiently for a day or two to be seen in clinic. And we go through and we see all the patients. And we try to triage them, and we've developed improved gradual friendship relationships with the general surgeon down there. And in the beginning, we just saw patients in the order they got in line, and now we triage them. We say, okay, can we have maybe the kids come to the front, the people who have burns and cut tendons, etc., come to the front, and they allow us to do that. And then we are able to triage the people. We get through them all by the end of the week, and we generate a surgery schedule after the first day and operate the rest of the week. This is a side note to volunteer work. A lot of healthcare volunteer work is difficult to be able to get involved in an organization that you can go on a trip for only 1 week at a time. And I think this is just something that prohibits a lot of people who want to do volunteerism from going early in life, in that most things are at least 2 weeks, if not 4 weeks. And it's very hard to carve that out of your life, and especially when you're young and in a new job, etc. this organization has afforded me the ability to go for 1 week at a time, which has made that a very realistic thing for me to do, and that's probably why I've been 10 times. I can get away for that long. This is David Cates. Some of you may know David. He lives here in town. He's the executive director of our program, and he's El Jefe, and kind of helps control things. He looks like he's had a few hard days on this in this picture. But the reason this picture is up here is to show you kind of what it's like with clinic. Everybody's pushing in the door, and every time you open the door, everybody tries to push in and say, me too. It's like, hey, we'll get to you, we'll get to you. I think they've probably seen people come and go and shut the door at the end of the day and say, that's it, which we eventually often have to do too. One of the major problems I see is secondary to this instrument, the machete. It's a ubiquitous tool down there. You see old guys walking around the street, young guys walking around the street, almost always guys walking around the street with their machetes, used for anything from butchering hogs to cutting the grass, and everything in between. And that machete does not always go where it's supposed to go. Now the gross pictures may come if anybody has a queasy stomach. I arrived in Honduras and getting ready to start clinic, and the general surgeon says, can you come see a patient? This fella had gotten in a machete fight. His cousin was killed in the machete fight, and he had gone to block a machete shot at his head by putting his hand up here, and you can see that his small finger was here, was here, and that thing went all the way through his hand, almost severing his entire hand. And so on the day of arrival, that's what we spent the day doing, was putting that guy back together. He luckily had enough blood supply from over here to actually feed these 3 fingers. I had to amputate his small finger. These are his joints, cut all of his tendons across his hand. We repaired as much as we could. We tacked some nerves together. How he did, I don't know, but he still has somewhat of a hand. So it's tough. I mean, you know, he could have been one of the 90 out of 100,000 people, but instead his cousin was, and he had this. So we see a lot of congenital deformities. You can see this person has 6 fingers, 2 thumbs, and I've got several pictures of a variety of these things. This kiddo had what we call a syndactyly, so he's born with these 2 fingers stuck together. It's a failure of separation in the womb, and I'll show you another one of those in a minute and show you what we do for those. This is a fellow who showed up with his arm wrapped up in a towel and sock, embarrassed, couldn't get a girlfriend or a spouse to save his life because he'd had his fingers chopped off with a machete, and somebody had done what we call a groin flap and tied his fingers to his belly, and they tied it in where he had hair. And so when they separated him, he's left with these things, and they were super floppy. And he showed up in our clinic on the last day. And I was like, I will be back. Please come back. I can help you. I've never seen him again. Unfortunately, I don't know what happened. I look for this guy every time I go down. Because I think socially, he's crippled socially. And it'd be a simple thing to fix for him and make him a lot better. This is an old trauma, broken bones repaired as we would here, but went ahead and developed what we call a synostosis. The 2 bones grew together with extra bone, and we took that down. When that happens, you can't rotate your forearm at all, and a farmer is worthless with a paddle, you know. So we took that guy to the OR and excised all that bone. Does have a chance of recurrence, but when we took him off the table, he had full forearm rotation. So this guy these are burn injuries from childhood, falling in a fire or near a fire as a child. He had a contracture in his elbow, or pardon me, his armpit, moderately in his elbow, and then this horrible contracture of his wrist. This is his, you'd think this is his thumb, but that's his index finger. This bump right here is the remnants of his thumb. And he also came in on the last day. I was able to get him to come back the next year. And what we did was we took this down, fused his wrist straight, so got rid of that flexion for him. That's a big web. And then little did I know that that bump was the base of his thumb. He lost most of his thumb, but that's his metacarpal, which is, so essentially from here back he still had. And we dug that out and created a base. And I was hoping at a later time that we might be able to transfer this index finger, which kind of is worthless to him, to the base of his thumb to give him we call it a pollicization, which is creating a thumb out of an index finger. He has not come back, so that part has not been completed. But this is all skin graft to make room, because when we opened him up, it created large gaps. But again, that arm was worthless to him as a farmer, and hopefully now he can get it in space and hold on and at least be a helper hand. Here's one of these syndactyles, and these are how we make the incisions to create skin flaps and create a web space. So this isn't supposed to be a medical talk, but these are other problems. An adult with a congenital deformity didn't want to do anything. He just came to clinic, we talked to him, and he said, I'm fine. This kid has a complex problem that we can't treat when we're there. It's called a radial club hand, and you can see the arms way off, the hands are way off the arm because of a lack of development of part of the arm. Both arms, that kid's going to have a tough life. So this is the operating room, and this is the anesthesiologist that comes along. I take a team, entire team, including anesthesia, ortho, surgeon, operating room nurse, scrub tech, and a PA. And I met a PA when I was giving a talk to the Idaho PAs. Who came running after it, and my friend introduced me for my talk and told what kind of volunteer work I did. And after the lecture, he comes running after me and asks me all about it. And now he goes with me every year, speaks Spanish fluently. He's a vital part of my team. He's doing stuff all week, finding new patients and hustling the hospital, and it's just invaluable. But we bring an ultrasound down, can do blocks. We do a lot of the patients awake, which is super nice for them, because we try not to keep them in the hospital, because that's just another big pain for the families. Sometimes we work under adverse conditions. Lights go out mid-operation, everybody dons a headlight. When I first went down and I was using all their equipment, this little dark spot right here, you'll be happy to know, is a part of the sterile sheets, but I'll give you a close-up. That was sterilized in the sheets. So it's a little adverse, but nowadays we have all this equipment down there. We've built a shed at the Save the Children facility. We keep equipment down there. We take new equipment. We take some equipment to donate, some equipment for us to use. And it's gradually helped them and helps us. Another kiddo, this is not how I feel about you, and that's not how the kid felt about me, but that kid didn't have a tendon, so could not flex that finger, so we fixed that. Here's a picture of the ward in the hospital. Like I had mentioned, there's about 4 or 5 beds in every, so they have a women's room, they have a men's room, they have a newborn room, they have a lactating mother's room, they have a peds room that are all like this. The hospital is quite dirty. You walk through slop on the floors frequently. Not less than once I've seen dogs in the hospital just walking around. It's questionable hygiene. But our team you know, one thing that's difficult is figuring out relations and with language barriers, and we do things differently than they do things, and we work hard not to step on people's toes, yet get our job done and stay out of their way so they can get their job done. But we've all become friends over the years, and more as the years come, they're welcome us. Before it was just kind of, you know, hello. Now big hugs and welcome back, and it's a great feeling to have those relationships. And we've have relationships with this gal runs the autoclaves and cleans our instruments overnight, and she hustles her butt while we're there, and it's great. So then evening, we all reconvene and have a good time over beers and dinner and share stories and laughs, and so that's great. This fella came to me with, this is the first patient we ever saw in follow-up. So this guy had cut all his flexor tendons, and we repaired them. And a year later he came back, and we got a picture of him holding his, having a Coke and a smile. So he had a good result. Standoff of the Honduran street dog and the vaca in town. You'll find scenes like this frequently. That may be the end of my slides. So anyway, you can see there are all kinds of ways to volunteer. And as a physician, I always thought that I would do volunteer work. But I didn't know exactly how or when in my life. And the time factor is probably what drew me to do this. And when I did it, I was nervous. I could have gone on an Interplast or a Doctors Without Borders trip where you're a plug-and-play doctor. You know, things are set up. The local doctors have already screened patients, and you get there and you could do 100 cases. You could help more people. But when I got here and realized several things, these people would go to Minneapolis as soon as they would go to Tegucigalpa, where a lot of them would have to go to get help. Tegucigalpa is the capital of Honduras, and it's only 3 hours away, but 3 hours away could be a lifetime in terms if you don't have the money, you don't get there. I realized that I'm helping people who never would get help, even if they were going to one of these American organizations or European organizations that are in that town. And I've had the opportunity to create something. Sometimes I feel like maybe it's a little bit rogue, but I actually took another retired hand surgeon from Great Falls there last year who's done volunteer work in Honduras and Guatemala and around the world, and he was confirming that everything we were doing was on the up and up and is a good thing. So it's super gratifying to do volunteer work. I have the good fortune of, you know, being able to change somebody by separating their fingers or fixing a fracture, and it's a very palpable, has a very palpable end result. Sometimes there's, you know, question if you're treating chronic disease for 1 week at a time, what is the value of that? And I think some people that volunteer that go on our trips and do that have that question hang over them to some degree. But I think that everybody gets something out of these trips, even if it's just an ambassadorial or cultural exchange and learning about how other people live. The first time I went, the flight from Minneapolis to Miami was longer than the trip from Miami to Tegucigalpa, and the change in worlds was unbelievable. Not that there's not a big change between Miami and Minneapolis, but Tegucigalpa is a different part of the world. So I always encourage people. I think a lot of people get in their careers and say they're going to do something overseas. They get busy and they say, I'll do it towards the end of my career when I have more time. I would encourage everyone not to allow that to happen to themselves and do it early in your career. I mean, even when you have young kids. I started going when my kids were small. My wife was super supportive, saying, this teaches our kids that this is an important part of life. And so it's really been enriching. So I hope this is helpful to you guys in learning how things go on in terms of medical exchange work. I think that we live in a special place, Missoula, to create an organization that does things like this that make real differences. We can't change the whole world. You got to pick a place and a time and do something. And you can always sit around and say you're going to do something. But anyway, I'd love to take questions, and I can add on as we go. Yeah, hey Chris.
Andy, what you're doing is obviously incredibly important to the people that you see each time, but in the 10 years that you've been there, looking back on that, if you were king for a day, how would you try to change the system, or where do you go to change the system that they don't need the volunteer doc coming down to?
Yeah, I think that's, in this situation, I think it's difficult. You know, I think you have to train more doctors. And in their system, maybe you don't train doctors, you know, you don't have hand surgeons, but they need an orthopedist. And they have a guy that I worked with when I first went there. I was in medical school. He was a social intern. And he became an orthopedist. He goes back to town. He does some very basic orthopedics. He doesn't do anything in the public hospital. He treats private pay. So he's not, I wouldn't use the word profiteering, but he is there to make money and improve his setting. So how you get somebody to enter into caring for these very underserved people is a very difficult and great question. This general surgeon in this town is a saint. He grew up in a family of 12 in a poor town. His mom sent him to his second mom, who educated him in Tegucigalpa, and then he came back and runs the kind of the surgical end of medical care in this La Esperanza town, and he works nonstop. And his wife's a pediatrician. They own a hotel. I mean, they're nonstop. Raised 2 kids who go to, their kids are bilingual, and I think they're probably both going to go to medical school. Yeah, so it's those families that are going to change things. They raise 2 kids who become doctors and come back to these towns with some kind of specialty training. You know, a lot of these big organizations do, you know, it's you know, teach a man to fish. A lot of these big organizations do help in the teaching hospitals, teach new techniques to people. I try to teach some to the general surgeon things that he could do on the ground there. You know, and as much as he has the time and the guts to do, I mean, he is not hamstrung by medical legal issues like we are. So he does do things, like he treats club feet, which, you know, there's this little tenotomy technique that could be done to treat club feet, and I guarantee you he changes lots of people's lives by doing that. So, don't know if that's an answer to your question or not, but.
Just a comment. I think I agree with you that the time frame available for volunteers at your station in life, you know, this answers your need and their need, and it's excellent. It's super. My experience with Doctors Without Borders certainly was not plug and play. You know, in the jungle in Papua New Guinea, trying to establish medical care was, you know, reminded me of a lot of the pictures you showed. There was not a way to walk in and just go to work,
Right.
for sure. There are many sites like that with Doctors Without Borders that are not plug and play.
Oh, I didn't mean to down, no. I'm sorry to,
That have been established for
Right.
a number of years, and
Right.
it's easy to fly in and go to work and
Fly out.
right, and there's a lot of that, like in Tegucigalpa. And I guess that was the only corollary I was trying to draw on that, and I'm sorry to have generalized. Yeah. Yeah.
But there are a couple of things, if you get further in your life so that you have time frame available, the Doctors Without Borders now will take 3-month assignments. And there's a new collaboration with Seed Global Health and the Peace Corps, and what their focus is teaching in medical schools and teaching nursing, rather than going in and providing a service for a short period of time. They're trying to help build the medical base. So that's kind of an interesting approach to solve the problem of what do you do? You know, how can you change it? So I think medical education might be a way to assist.
Any thoughts, Tom?
I'm shocked you know way more about it than I do.
Not true. We're always looking for, volunteers, Spanish speakers, medical care providers, donations, the shameless plug. You should take a quick look at our website. It's MissoulaMedicalAid.org. And there's a great video that was produced by a fella here in town named Colin Ruggiero. Some of you may know he's one of the Drum Brothers. And he produced a really kind of insightful film to what's kind of going on in that area. It's a 10-minute view. Yeah.
You mentioned that you brought a medical team down with you. How's that financed? Does everybody pay their own way?
Everybody pays their own way. Yeah. We have one major fundraiser a year, and we have every volunteer has to generate a certain number of dollars, which is about the average amount that it costs to send a person down there. And so some organizations charge you extra money to go. It may cost, it's about $1,200 to get a person down there. And some organizations, when you go with them, have like a minimum of $3,000, which really cuts a lot of people, especially college age or soon after college age kids, out of the equation. We charge, we ask everybody to generate about $1,200 or $1,250 to go. We used to only get people to do $650 because of the same reason, to try to keep people coming, but that was breaking the bank. And unfortunately, without money, there's no mission, right? And we have a great fundraiser every year, the Salsa Ball. It's at the Children's Theater every year. It's a super fun party. And we'd invited people to come and see what we do. And we auction off things, try to auction off things that we buy in Honduras, so people can see what real Honduran goods are. And it's always a fun party. But yeah, thanks for having me. Anybody else have any questions or?
Thank you
Yeah.
enormously. And
Yeah.
I always wondered